Great. Hello, everyone. Thank you so much for tuning in to our webinar today on a very important and complex topic, MNT insurance reimbursement for dietitians, with a specific focus for what is going on in Iowa. Please feel free to share in the chat your name, what area of dietetics you're in, anything else you want to share, maybe where you're located in Iowa, so we can start to get to know our audience and our participants here today. I'll introduce myself first. My name is Kat Rudolph. I am the state policy representative for the Iowa Academy Public Policy team. Thank you again for tuning into our webinar. I also wanted to introduce our other policy members. So we have Caitlin Sherman. I don't know if you're able to put your video on right now and just give everybody a wave, but she is our public policy coordinator. We also have Tina on the call as well. She is our consumer protection coordinator focused on licensure issues in Iowa. And I will introduce Kara here in a minute because she's one of our speakers today, focusing on reimbursement as a reimbursement representative for the Iowa Academy. I also want to encourage you as we're getting started to please feel free to share questions as they arise during the presentation. Just go ahead and put them in the chat. If we have some time, then our speakers will address them as we go. Insurance coverage can be a really complicated topic. So we want this to be a conversation and we want to help everyone feel more knowledgeable on this topic. So again, feel free to share any questions that you have. So now I'm excited to introduce our speakers. We have Kara Wiggins. Kara is a registered dietitian and certified athletic trainer with the Performance Collective. Sorry, just going to make sure that everybody is muted. Oh, so sorry, everyone. Going too far. So Kara Wiggins is a registered dietitian and certified athletic trainer with the Performance Collective. She is a Michigan native and holds a Bachelor of Science in Athletic Training from Saginaw Valley State University and a Master of Science in Nutrition from Auburn University. Kara has settled in Iowa after spending the last 4 years working with the professional baseball team, the Toronto Blue Jays organization. Since she settled here in Iowa, we have been lucky that she's been following her passion of improving access to dietetic care for individuals, volunteering as our reimbursement representative for the Iowa Academy of Nutrition and Dietetics. Then I'll have the opportunity to introduce you all to Jennifer Pope, Jen Pope. She is the owner and lead registered dietitian at Roots Nutrition Counseling, which offers nutrition counseling services, meal planning support, and in-person cooking classes and demonstrations. She has a Bachelor of Science in Dietetics from Iowa State University and a Master of Science in Nutrition Diagnostics from Cox College. And finally, we have Domna Antonia Diaz. Sorry, I messed it up again, Domna. You can correct me. Antonia Diaz. For over 10 years, she has been an attorney with Legal Health, the nation's largest medical legal partnership. She has worked extensively with providers and patients to address health-harming legal needs, with a focus on navigating barriers related to health benefits. In 2020, she was named 2020 New York City 40 Under 40 Rising Star by City and State. She is currently pursuing a master's in public health at Yale University. And in April of 2023, she co-founded the Access to Care Project at the International Federation of Eating Disorder Dietitians. The Access to Care Project aims to educate individuals on their rights to challenge health plan denials. Its mission is also to empower self-advocacy and coordinate for systemic change. I also wanted to note that we have Kim Isles on the call as well. She is a policy staff member at the National Academy of Nutrition and Dietetics, and she focuses on reimbursement issues as well. So she is here to chime in, to provide any education, answer any questions, and address anything that's happening at the national level that we should also be mindful of. All right. And here are our objectives today. We hope to summarize the status of insurance coverage for medical nutrition therapy for dietitians here in Iowa, discuss how to go about speaking with insurance companies about barriers to care for patients in Iowa, and start to generate conversation around what skills, strategies, or action steps we can partake in to help to increase insurance coverage for this service for dietitians in Iowa for the benefit of us, but also to our patients and clients. And with that, I will hand it off to our speakers.
All right, thank you so much, Kat, for the introduction. And thank you all for joining us. We have such a great crowd here. So we wanted to start off with some terms and concepts around insurance reimbursement, just to kind of make sure we have these kind of settled away at the beginning of the presentation. So we'll be talking briefly about NPI numbers and electronic medical records as a way of streamlining some of our credentialing process and our billing. And some other concepts that we wanted to talk about that are specific to Iowans are the credentialing with insurance providers. So to credential with an insurance provider, RDs will have to hold a credential from the CDR, a Iowa license as an RD or RDN, their NPI number we have described here on the left, making sure that they carry liability insurance for certain credentialings, potentially complete a background check if that would be a required necessity for that insurance credential process. And then we'll talk about a little bit when Jen comes on for our next slide, the CAQH versus credentialing with an individual provider. So whether we want to do it once in a general form and credential with multiple providers in one streamlined way, or if you want to do individual credential with individual insurance providers. And then in today's world, most of us work through electronic billing. And so knowing different clearinghouses that can be a mediator between you as the provider and the insurance provider where the claims will be submitted. So these are going to be concepts we'll be talking about with Jen's experience in private practice. And we'll dive a little bit deeper into some of the nuances as well when we're talking about claim denials with DOMNA and how to support our patients with advocacy for their insurance benefits. Okay, so additional things that we wanted to present to you today. As a registered dietitian, if you are billing as a private practice provider, or maybe you are billing incident to the MD at a facility, these are some common codes that we see through nutrition counseling or medical nutrition therapy. There are other codes that may be applicable to nutrition services, and the Eat Right Pro website has a really great PDF booklet called The Complete Guide to Billing and Credential Essentials for RDNs. So if you are looking at additional nutrition coverage that you'd be curious if any other codes could be submitted and reimbursed, I would encourage you to go to that resource to be able to maybe talk through your provider or with your practice group to see if those codes would be applicable to your setting. So when we're looking on the left here, we see ICD codes. Those are medical diagnoses, and those are things that we need to make sure are documented for our MNT services. However, if we're working with preventative health benefits on someone's plan, we want to make sure that we are utilizing Z codes. They are not diagnostic codes, and we can assign Z codes without a physician referral as an RDN because they're not necessarily a medical diagnosis. So we'll just have those as a resource here. And then Kim has dropped that PDF in the chat as well for you guys. That's just a really easy way to access that information. Okay, and so on these couple of slides, we'll have Jen joining us to share her experiences about medical nutrition therapy and private practice. So Jen, if you want to introduce yourself and a little bit of experience around specifically some of these entities that you work with for your clients.
Absolutely. Thank you so much. I'm excited to be a part of this call today. So I have been in the private practice world for about 3 years now. I previously worked as an outpatient dietitian at Mercy One in Mason City here. That's where I'm from. The outpatient program I worked in there was brand new. And so we had a lot of experience figuring out some of the insurance ways before I jumped into private practice. So what I'm sharing today mostly is just my experience in the private practice world, but I do have a little bit of insight of what it looked like to be a part of a larger health corporation as well. So they did vary, and I think maybe I learned that the hard way in private practice, which is just makes for tough skin. So here we go. I'm happy to share all of this today. If you have questions, I have my chat up, so hopefully I can answer as we go, because I know there will probably be quite a bit. So for the medical nutrition therapy in Iowa, I really try to kind of categorize everything. So I picture it as like your big commercial companies, so like Aetna, Cigna, United Healthcare, Blue Cross Blue Shield, the Wellmark product, which is Iowa and South Dakota, and then out of state products, which do vary quite a bit. The two, again, hard lessons to learn there, but kind of trying to summarize for you in the private practice world, what diagnoses I see covered through some of these companies. Medicare I have a good appreciation for, simply because they're very black and white. So they tell you what it is and what it isn't, and then you just kind of go from there. So they are covering for diabetes and chronic kidney disease stage 3A plus. Medicare, again, very black and white. And we'll talk about some of the referrals and stuff like that, but you do absolutely need a referral for Medicare. So I have great luck with them because, again, black and white, it's very, very easy to see. As far as like most of the other major companies go, excluding Blue Cross Blue Shield, we'll talk about them. But like Aetna, Cigna, United Healthcare, Oscar, Medigold, Humana, some of those companies, some smaller ones there, but they cover mostly obesity. So a little disclaimer about my practice, I would say 85 to 90% of the patients I see are weight management patients. So most of them being middle-aged adults, both men and women, who want to try and lose weight. I see some children in that category as well, and some that do want to gain weight. But a lot of times, most of this is just all based off of BMI. So we all know some of the margins of error for BMI can work in our benefit for some of this stuff. So most of my practice is just covering for weight management. So I do see that most of those companies will cover for obesity codes. So I've had some with diabetes, kidney disease, and they actually tend to favor a BMI code, which would be a Z code, like Kara mentioned in the previous slide. So if you need to bot back to that Z code is not a diagnostic code necessarily, but something that needs to be documented, and then pairing it with the Z code of Z71.3, which indicates on the claim that it is preventative healthcare, which is what is so great about a lot of these companies. They're honoring that policy that we know to be true in the nation, that we need to provide the preventative healthcare. So a lot of those common diagnoses, I honestly, in my practice, haven't had a lot of eating disorder patients or some GI things, not a whole lot, but I have not seen them be covered in the private practice world. When I worked for a larger health corporation, they were covered, but there's a difference between in the larger corporation, we were using the MDs or the referring providers. So even mid-levels like nurse practitioners or PAs, but we were using their NPI number to be on the CMS 1500 form, the insurance form, versus in private practice, it's the RD's NPI number. And that's where some of this gets a little bit tricky. We'll try to keep that clear as we work through.
Yeah. And so that's kind of where we get down to the Wellmark Blue Cross product as well. So individuals who work as a part of a larger health entity and are being able to bill incident to the MD or mid-level provider will see more additional coverage in those GI cases, cystic fibrosis, et cetera, whatever is written into their plan form. But when it becomes to an out-of-network provider, that's currently maybe a little bit of a different route for those nutrition and counseling patients. Now, when we are coming to the Wellmark section of this slide, that's also another catalyst for today's presentation. So we know that the current state of providers for RDNs are not listed on the Wellmark as an in-network provider, but that's actually part of some of the advocacy work that we're doing today. And we'll be touching that on later slides of what we're doing to improve access to be getting RDs as a listed provider and improving access to nutrition services in private practice dietetics.
Yeah, and it's a great journey with this. But what I know now, and again, this is just my experience of what I have seen for Wellmark Blue Cross Blue Shield. So Wellmark being the Iowa and South Dakota product. So we as RDNs are considered out of network providers with them. So what that has meant for me is that when patients are deciding to use an out of network provider, in kind of a roundabout way, the insurance, they're not in network, right? So they want to, it's not as easy for them to access from the out of network providers. So things look a little bit different. In the private practice world, diabetes, kidney disease, obesity, hypertension, hyperlipidemia are the 5 diagnostic codes that I have used and had reimbursed through Wellmark Blue Cross Blue Shield. It's out of network, so the process of reimbursement is a little bit different. Just to kind of give you a brief overview of that in general, and it gets kind of muddly. So if you have questions, please ask. What it looks like for us and how we kind of found this out is that it was hard to get a really clear answer, but we're out of network. So everything that's going toward, like the patient's going to use, they will cover those diagnoses after the patient has met their deductible and then use their out-of-pocket max as well. And that we know that varies for everyone. I know much more about insurance than I ever would need to know. But so they have to completely satisfy their deductible. How do you know what their deductible is? Well, we call Blue Cross Blue Shield and do that verification process for them. I choose that as a private practice dietitian. I know many other private practice dietitians don't do that. It ends up taking quite a bit of time. I've done it since the beginning. So we kind of have an efficient process with it. I have a verification form that I call on and kind of walk through a process with them. So we call to see what that deductible and out-of-pocket max is and how much they've satisfied. I find it important in my practice to give that information to the patient ahead of time. Whenever there's gray area or I put it on the patient as their responsibility, there tends to be like, well, they told me this and I heard this and then this happened. So I just take on that responsibility and find that it works best for us that way. So what they're actually doing for these, they're covering them if they fully met their deductible, and then the out-of-pocket max, there's a little bit of a co-insurance. So they would owe until they meet their out-of-pocket max. Every plan is so different depending on what their health insurance coverage is. The biggest difference is that then Blue Cross Blue Shield sends the payment to the patient. So they will send a check in the patient's name to the patient in the mail. It's one sheet of paper. It looks just like an EOB, very easy to throw away. So that happens quite a bit too. We learned that the hard way, seeing on Blue Cross Blue Shield's website, check written this date, check written this date. And we're like, where are all these checks going? We have yet to get a check. It's been like over a month. So then we found out that patients were getting the check. So the payment process looks different. For the other major health companies, we can use ACH payments, so automatic deposit into the business checking account. For these, we are watching the payment status, calling the patient when the check is issued to them, say, hey, keep a heads up, your payment's in the mail, it should get to you in about 5 days. Call us when you get it. We'll follow up with them. They got the check, they deposit it into their account, and then we charge their card or their preferred payment method. So that's the big difference. In addition to having to do a little bit of kind of work on the forefront of verifying benefits, the payment process does look different in that way.
Yeah. And thank you for sharing that too, because I think, as I relocated to Iowa, I learned that Wellmark Blue Cross Blue Shield is one of the largest insurance providers here in our state. So we're letting Jen go through and explain some of the nuances to that specific carrier and how that looks, because it is probably maybe one of the most widely used insurances for our target population. And so, she was saying it was going to look a little different with maybe an Aetna or a Cigna and how that goes direct deposit, but helping you guys understand that it can be done currently with Wellmark. It just may look a little different.
Absolutely. Yeah. And again, that's kind of some of the differences between private practice dietitians versus a larger healthcare system. When I was working for a larger healthcare system, though a lot of different diagnostic codes and medical nutrition therapy services were covered. I think that Amy shared in the group chat that she had maybe done an eating disorder code with United Healthcare and that worked. But so in that larger healthcare system, and she's in private practice, so that's great information. In that larger system, we saw almost everything kind of be processed because it was under a different NPI number. It wasn't the RDs. And in private practice, this is only my NPI number. So that's where some of this information is coming from. And then Blue Cross Blue Shield out of state. So I've had some good success with that. That one has been a little trial and error. I haven't found the verification process working for out of state. I kind of chat back and forth with other private practice dietitians, Amy being one of them on the chat here, about, hey, we have a New Jersey one. Have you had anyone on this? So I actually have had some pretty decent luck with out of state plans. Those usually come from patients in this area who work for larger corporations, big manufacturing companies that have different plans. But the diagnoses are usually pretty much the same. I guess I kind of try and tread the path that I already know with some of these things. If I get something that's completely off the radar, out of key with some of these codes that I'm used to using, I might put that responsibility back on the patients, just because out of state is so hard to get an answer with. But for the most part, again, my practice is mostly weight management. So it's usually an obesity, diabetes code, something like that coming towards me. And then we work through what each of that looks like. One thing I'll mention for the out-of-state Blue Cross Blue Shield is that, and I share this with patients, if you run it through their insurance and it goes towards their deductible, they are liable to pay that, right? We can't just be like, oh, never mind, and then go that way. So there is a little bit of a few hiccups to work through with some of that stuff, but I find that they're usually pretty decent.
And so when you are working with out-of-state Blue Cross Blue Shield plans, are you also considered an out-of-network provider there as well for our audience today?
Yes, it runs the same way. So if you look at the back of anyone's out-of-network Blue Cross Blue Shield insurance card, it says run it through your local product, and that's what kicks it to being the exact same for the codes that I honor, and then the whole payment process is the same as well.
Thank you. Yeah, thank you for sharing.
Yeah.
Okay, so I think we can transition.
Next slide if you're ready. Okay.
Yeah. Yep. All right. So yeah, Jen, if you could talk through your experiences credentialing, did you go through an individual provider for each individual insurance provider, or did you use the CAQH?
Yeah, I use the CAQH for the majority of them. I think it's like going through one I covered the process. I didn't have a ton of resources. I did use a reimbursement specialist, which was really, really helpful. But I did use the CAQH platform, which was so helpful because everything's in one spot. You can make sure it's the right document. You're uploading liability insurance and things like that. And so it's just easy to access. On that platform too, you can also see when they viewed your application and things. So I found CAQH to be very, very helpful. It's just working your way through it. And I think there's a lot more resources now, but it's just kind of working your way through it and knowing what they're asking. That was the biggest thing for me, is I guess kind of second guessing myself. I didn't always have that reassurance piece of it. But yeah, for the credentialing process, it was a little bit of a longer process, but I would say on average in like 3 or 4 months, I was really able to kind of accept from most of the major insurance companies. United Healthcare was probably my first one. It went really, really easy. So sometimes I'm like, is this too easy? But you do have to show proof of some of those documents, like the liability insurance. And like I said, the CAQH platform just made it really, really easy to use.
That's great. And so you mentioned the proof of liability insurance. In any of your experiences in credentialing, were you ever required to do any type of background check or disclosure of any background information?
When I was going through some of the companies, they will ask you like if you've had any issues or things like that. I didn't have to go through anything real formal, but it was more so company by company.
Okay. Yeah. Thank you for sharing. All right. And so, yeah, and then you can walk us through the rest of what your coverages have looked like, and maybe some of the FSH or HSA and FSA eligible maybe clients, what they're using to cover some nutrition benefits, and just kind of walk us through some of your experiences.
Yeah, absolutely. So coverage has been shockingly pretty thumbs up for me. The Blue Cross Blue Shield piece is kind of that separate entity, but for most major insurance companies, it's been a great process. So I would say like they will cover of my visit charge, 80 to 100% of that. Some of them based on the plan will max out like, okay, you only have 5 billable hours in the year or things. But for the most part, really, really good on coverage. For patients, and again, this is just my perspective and how I run my private practice, but for patients who maybe have that higher deductible plan for Blue Cross Blue Shield or don't want to go through the process of getting a referral from their provider or things like that, they will use their HSA and FSA cards and payment methods. So how I run it is I have a self-pay option that they will pay me through their HSA card. Some patients will pay it with their normal and then submit it to their insurance company or to their HSA, FSA. But for the most part, they all have a card that we use there. It is, in my opinion and in my experience, it is the patient's responsibility to know what fits their HSA, FSA program. So that's a great benefit if someone's like, I use Medicare is a great example. So they might have a separate account for something like that, and they have obesity but not diabetes or kidney disease. They can use things like that. So we try to use that as a good promotion point of like, you can also use our services for some of those things. The coverage again for the Blue Cross Blue Shield, as I mentioned, the payments will go to the patient, and we kind of do the reverse on our end. So again, a lot of it is just how you want to run your practice and what you find, how I kind of like, some of it's a risk-based thing. So I talk about documentation is needed for most companies. So like, I choose to get a referral from people's primary providers for the reason for their visit with me. One, I like that it keeps open communication with their providers. They know I'm a part of their care team instead of feeling like maybe it's a threat of trying to take something away from them. But then the second part of it being, I just want to triple check, cover my bases. Again, we know those rules and regulations with not diagnosing anything. So I just play it really, really safe in my world. I think 3 to 5% of the time we might have an issue, and then I can take it on a case-by-case basis. I might have their past office note that has the diagnostic code, which is technically documentation, but still might try for that referral just so I have it written separate with a signature and a date. The one thing is Medicare absolutely needs a referral. There's no ifs, ands, or buts about it. And every single year you need a new referral for that patient. So that's a big, big piece with the documentation part of it.
And then for you, using an EHR, is there maybe one that has worked better for you? Have you transitioned between EHRs and utilizing for insurance claims, or have you stuck with the same one from the beginning of your journey?
Yeah, I have used Simple Practice from the very beginning of my journey. Honestly, I got on the Facebook pages and I started to look and see what people were using. My reimbursement specialist had used that before too, and I found it to be easy enough. So I do everything through Simple Practice. I know there are a ton of other ones, and there are some that I know a lot of dietitians who are kind of chatting back and forth here have used as well that they like. So I do all of my claims and filing through Simple Practice. It's worked fantastic for me. I do have someone who works at my front desk. And so she puts in all the demographic information, all their insurance information, scans in their card, everything for me. So then it will auto-populate into my claim form in Simple Practice. So it's really honestly a click for me, make sure everything's accurate, and then submit it. Simple Practice does have a clearinghouse attached to it. So it's going through the clearinghouse there. You can tell when it comes back if it was rejected at the clearinghouse or simply a denied claim from the payer. So that's nice to be able to see. But then I do the work on the back end for denials and stuff like that. So I'm looking into it. I'm calling the insurance companies, those sort of things, which can be a lot of work. It is a full-time job. It could be a full-time job. But I try to spend a lot of time on the forefront of it, making sure everything's right before we submit to the best of our knowledge, so we don't have to rework a lot of that stuff.
Yeah. And I think that will help us kind of transition to our next slide too, with some of the denials and such. So yeah, I guess your experiences, you mentioned you've been called insurance companies to make sure you verify some of their plans, their coverage, their deductible. But yeah, can you walk us through maybe prior authorizations and maybe any claims and experiences with denials that you've had?
Yeah, absolutely. So I haven't had to do a whole lot with prior authorizations. What I have gotten from them is when I do talk to companies, they will let you know if a prior authorization is needed. So calling the insurance company is a good way to know if you need one of those or not. In my experience with a larger health corporation, we did have to do some prior authorizations for certain companies, but that was done by someone else in the corporation. So I do know it varies depending on which company you're working with and what diagnostic codes you have. But yes, the majority of talking with insurance companies is just asking about eligibility of services. For most of the big ones like United Healthcare, Aetna, Cigna, I kind of now know what will roll with that. And since that's my patient population of the obesity, diabetes, that sort of thing, I feel really comfortable knowing some of those and not having to verify. But with all of them come denials and different things because there's so many different types of policies and so many different types of coverage that I'll call the provider line to figure out, what was the issue with the claim or what's the issue with the policy or things like that, and then communicate with the patient on that end. And then, of course, credentialing, there was always a separate credentialing line. So I did work with them a lot in the beginning on that. But now it's pretty simple and I don't have to call on that much, which is great. I would say overall, in general, working with insurance companies, the hardest thing is getting to the right person, getting to someone who knows the answer to your question. And that could be very difficult and very tiring, but builds thicker skin.
Well, thank you so much for sharing. And that really kind of tees us up for our conversation with Domna, because we're going to be talking about how if something, feels off or doesn't feel right, how we can further look into that for our clients. And so if you have a denial or a benefit coverage concern, how we can further look into our plans and be equipped to service our clients and get them the care that they need. So with that, we will transition to Domna.
Great. Thank you so much. And then I'm just not sure. Oh, here we go. Okay. So nice to meet you, everyone. I am putting in some things in the chat. So let me put this in now. So I'm going to be pulling from slides that are from a larger presentation that are based more on eating disorder specific issues with medical nutrition therapy. So a lot of the information is relevant across the board. So that's what we pulled. But if you want a more in-depth specifically about eating disorders or ways to advocate, you can see the bigger slides. So yeah, a lot of times we think about health insurance as it's the wild, wild west. I mean, I think Jen, you made it perfectly. The issue is finding someone who you can talk to, who has any idea about what is going on, which in some ways is baffling considering how large and how wealthy these companies are. But it's something that we actually do need to remember, that it's regulated. So there are actually rules. And although we don't necessarily believe it, democracy is actually meant to establish several core components. I see Kara smiling. And it's that things are supposed to be fair, accessible, and transparent. And so that means that when you're dealing with Medicaid, health insurance, you should be running those words through your head. Does this feel fair? Is this accessible? Am I able to get in touch with anybody? Is it transparent? Do I have any idea of where they're getting this information? If I have a denial, do I know what it's about? And so most of the time we feel that answer is not answered. That question's not answered. And we kind of sort of shrug our shoulders and say, well, that's not fair. Which goes to that other one. And we move on. But actually, because it is so regulated, there are ways where you can report complaints. And I'm not talking about lawsuits. I mean, nobody can do those anyway. But it's actually talking to your state insurance department, talking to your local congressperson. And there's a lot of ways that you're able to actually advocate in a way that is very meaningful. So we're going to kind of just go to the next one. And I'm going to just walk you through a little bit about what this product is. So every health insurance, it's you get a manual. It's your contract. It's that 150 page document that goes through every little thing. It says, who to call, what the timelines are, definitions, exclusions, inclusions, cost sharing. It is this massive, large document that we usually never bother reading, but is actually so important. And I think, again, one of the good things that Jen kept pointing out is incorporating things into your office management. So this is something when you're intaking with somebody, you can just have a handout or have something that says, ask your employer for this. And then that way you can just upload it into their patient file. You may never need it, but it's there because when you do need it, it's impossible to get. So that's just something that you can use to start to create a system where you're able to get this document that fully describes everything about this plan. So, we're going to keep going with the Kara, if you can, or Kat.
Oh, Kat. Thank you.
Okay. So again, a lot of this is things So we have the policy, which is written information about your plan. And then you have the explanation of benefits, which tells you what was the service, date of service, what was billed, in network, out of network, amount paid. And again, there's certain rules about what's supposed to be there. You should be able to look at that paper and you should know what's going on, what was denied, what was approved, how much, and what you can do about it. So oftentimes it's like 6 to 10 pages long, which we tend to ignore the last 9 pages, because it's all legal jargon. But legal jargon exists for a reason, which is to make sure things are fair, accessible, and transparent. So that's kind of the, where I'm going with this, is that there's going to be so much information, and there's so much there because lawyers think that regular people have time to go through this. But the trick is kind of to just figure out how to find things. It's sort of like a word search. You have the big policy, you word search nutrition, you word search dietitian, you word search credential. Everything has to be there because lawyers are paranoid and everything is there. And so again, it's kind of, we like to think about these things as very like heavy level things. They're not, it's common sense. Lawyers, we know they're crazy. I am a lawyer, so I know that. They don't trust anything. They have to have everything in writing. And that's the case with insurance because it's regulated. So, all right, let's keep going. I get very excited about this. Why are things denied? Every reason, not medically necessary, experimental, it's not covered, wrong NPI, it's supposed to be an incident to, you can go on and on about all the reasons. These are supposed to be in the explanation of benefits. When you're getting a denial or an underpayment, it's supposed to be there. Sometimes you'll just have something that says not covered benefit, or we made this decision based on the terms of your policy, and you have no idea what that means. So that again brings us to this component of, well, is this accessible? No. Is it transparent? No. And those are other opportunities where you can just like report a complaint, which are actually incredibly easy, and nobody does them, which is really helpful to know because it actually means that when you're reporting them, things happen because health insurance, either related to, obesity or cardiovascular care, mental health is like a very big, sexy topic right now. So all the politicians want to make sure that they're doing the right thing they're doing for their communities, that if there's an issue, if people aren't getting the care they need, that they're on top of it. And so what would it look like if your local insurance commissioner received 150 complaints that, United Healthcare or, Wellmark is not covering something? That's going to matter because when they're running for reelection, that's going to be picked up on and they're going to be flagged as being a hypocrite. If you're saying this is so important to you, how come you got all of these complaints and you didn't do anything? So again, we often think about, and I think it is really important, the more legislative Congress side, but a lot of the work that you can do that's relevant to your direct practice is very local and nobody does it, which is why it's helpful. So let's keep going. So, I think some of this we don't really need to go through is how do you identify the wrongful denial? You read it, you try to just find words that make sense. If it doesn't make sense, again, now you have a right to complain about it, appeal it. It's supposed to make sense. They're supposed to tell you what is the problem. They're supposed to tell you why that's the problem. If you don't understand it, then they're not doing it right. Okay, keep going. We can keep going with this one.
Oh, that's where Kat, can you pull back out and pull back in from some of the slides? There you go.
There we go. Okay, keep going. So this part is pretty much what are questions you should ask yourself. When you get the denial, what's the date? Why is it denied? Did they do it within a certain time frame? Because there's a rule about that. Are the facts right? Did you get a signed authorization from the patient if you need it? Did you ask for documents? Did you get them? When did you request them? Those are just things that you're kind of running through your head to kind of see, okay, what's going on? Is there something that might be happening? So then we kind of have, all right, what do you do after that? After that. You can keep going with this, actually. You can skip this one. So this I find really helpful is, again, back to what Jen said, make it a system. Just make it that it is part of your practice. We are already on the phone for hours and doing things that are such a waste of time. You have steps. Everything is the same, right? You know what you're getting. You know what you're going to see. There's usually 4 or 5 common denial reasons. You have a template. It doesn't have to be perfect, but it's something that then you can fill in. Another provider can fill in. Your admin can fill in. That way, it's just something that initially is challenging, but then just becomes part of a process. And because it's being done this way, you're also able to empower your patients, other family members to do this for themselves as well. Because a lot of times, right, we have things where if the provider is the only one that can contact the insurer and get someone, then you will be the only way that they will try to solve a problem. And so being able to encourage people to do this, to give them forms or documents on how they can do it, also really does help the entire system of the process, not just individually, but also for the individual. Individual for your practice and for the individual. Okay, let's keep doing it. So again, I am a very big believer in creating a system. So, I thought long and hard, what can you have in this? Okay, signed HIPAA form. So what do you do with that? During intake, if you have someone sign a form, you're probably going to need it at some point anyway. If you need to fill it in, you write, the HIPAA for the health plan, and then, Iowa Department of Insurance. You can have a folder, a paper folder, electronic folder, anything you want, but all of this stuff that we already do for other types of situations is something that you can do for health insurance. It's the same thing. It's the same process that you're always going to see. So why not try to use some of the things we already do to organize all this information in this type of way?
And if you, Donna and Kim, could you guys share a perspective of where this would fall into place? Maybe in an eating disorder situation where there is an eating disorder client and maybe their insurance has set a limit on the number of visits.
Okay, Karen, this is fun. This is fun.
I was just curious of where this would apply with some of our dietitians in the audience today.
We have something called the Mental Health Parity and Addiction Equity Act, which means health insurance isn't supposed to have more discriminatory bases for behavioral health or addiction conditions. Eating disorders are behavioral health, which means that they can't have limits on these treatments that they're not also basically applying on the medical and surgical side. So this has been around for about 10 years. It's been very challenging because there's been a lot of questions about MNT. Is this a medical service? Is this a behavioral health service? Well, if we have 4-visit limit for heart disease, can we do 4-visit limit for, ARFID? And just about a month ago, the government published a new regulation clarifying all of this and very explicitly saying that they cannot have the visit limits, that they cannot have these exclusions for behavioral health conditions and nutrition. They even they put it in, I think, 22 times in the entire regulation, and very clearly have emphasized that this is not permissible. So what is supposed to now be happening is that any of these gray areas where we're seeing visit limits or they're kind of fudging around with it, it's now very clear. There's not really room for argument. Will this fix things right away? Probably not. And that is why we go to the complaining part, because now you have an issue that it's not a debate. There's nothing to argue about. There's nothing where they're like, oh, we misinterpreted it. It is so clear. And one of the reasons it's so clear is, let's go to the next one. It might be there if not.
It's not.
Okay, so I'll tell you.
There is a gap in our slides, but we will update you guys with the full copy.
All right. So the reason that it is so clear is because when you're doing something with the regulations, right? Government, fair, accessible, transparent, they have to post a draft online for everyone to comment on. So last August, they published their 600-page document, and about 50 dietitians, we went through it and we were like, we're going to make comments. And they submitted a lot of comments. And because the government's supposed to be fair, accessible, and transparent, they actually incorporated some of these comments into this rule. One of them, they even actually added a footnote clarifying the definition of medical nutrition therapy, that it does not just mean like the Instagrammer online. And they added really specific information because the dietitians and family members provided this input. So I'm going to, make sure that you guys have time to transition for the next part. But, one of the things, again, that I do like to tell people is we get so much information, and that's unfortunate, but usually it's there because it's supposed to be helpful. But sometimes it's just good about like taking a step back and trying to think about it. If it was common sense, what do you think is here? And if you're kind of having just a few core thoughts in your mind, you can usually navigate things. And so I think my final thing is Google and ChatGPT are incredible tools. If you know that there's a question to be asked and you ask it, it will help you find things. Wikipedia as well. So that is my legal information for you folks.
Yes. And so if you're sitting in the audience and you're thinking, wow, so that's very applicable to me in my private practice as an eating disorder dietitian, or if you're in a group practice or a facility and treating eating disorders, and that seems applicable to you, hold on to that thought, because we have a survey at the end where you can reach out to us at the public policy team and we can help you navigate some of these policies and maybe some of your experiences to help you get into the right resources to help you advocate for your clients. And so hold on to that, and we will kind of re-follow that up on the very end for our last two links on our pages. So kind of transitioning, kind of wanting to wrap all of this up with additional resources for you as registered dietitians. There are a lot of good resources out there, and almost it can be overwhelming because there are so many. So it's like, where do you start? Where do you go? I've tried to really summarize things that have been really helpful to me as someone who's been new to this realm, and also to those maybe who have experience in this realm more than me. So there is a really great step-by-step playbook on the eatrightpro.org website that's called MNT Works. It will take you kind of through the start to finish of what it's like to kind of build out an MNT practice. So that one's going to be really great, and also will help you advocate for maybe new initiatives. Maybe if you're in a rural area of Iowa and you want to team up with a primary care physician to provide MNT benefits, it'll give you tips and tricks on how to reach out and establish those relationships with stakeholders in your community to help expand medical nutrition therapy. So that is a great toolkit. And then the other one is affinity calls. So joining affinity calls, there's two here. So if you're really passionate about just kind of working through individual insurance concerns, I encourage you to go to the reimbursement and payment affinity group. And if you're really passionate about advocacy and helping expand nutrition coverage and how you can be, a person of change in that realm, then I would also encourage you to join the affinity call for the MNT expansion. So those two affinity calls are going to be really helpful for you to connect with individuals like yourself who may be going through similar experiences, and have a resource in Kim Isles to ask questions, who has some really good extensive work in private practice, reimbursement, and also experience with the National Academy. And the other one too would just be an MNT provider newsletter, just as something to kind of continuously stay up to date on with all of the new happenings with CMS updates and insurance related to Medicare and Medicaid as well. And then I have another update, if we can flip the page, Kat. So we have additional things that are here to help expand nutrition medical therapy and things that you can get involved with. So the action alerts you may receive in your email, just encouraging you to fill those out and continue to advocate, because we can advocate for more coverage and more diagnoses, which will then additionally help our communities to be able to access care with insurance. And the next page, and why that's really important here for Iowans is because of our two senators. And so Senator Chuck Grassley serves on the financial committee at the federal level. So that's really helpful when we're looking at expansion for MNT with Medicaid, specifically with the MNT Act. And then Senator Joni Ernst also serves on a committee for ag and nutrition. So when you work through the MNT Act Now action statement and you submit your zip code, it will generate an email to our senators, and it will help them know that these are issues that we care about here in Iowa, and they can all help raise the boat together for all helping improve expansion to MNT. And this is specifically for Medicare, but we know that that can be really impactful by setting the tone for what should be covered in private insurance. So the next slide, we have a call to action. And so kind of what I mentioned at the end of Domna's presentation was, we want to hear from you. If you're having experiences and trouble with insurance, please write us. We're going to drop this survey in our chat, and we want to know from you if you have a patient or yourself regarding access to nutrition care through insurance. Please share your story with us as we work through our advocacy efforts. We do understand the well-marked Blue Cross Blue Shield is one of the most prominent and pressing issues, but we also know and we are aware of the Medicaid in private practice as well. So if you are there and able to share your story and how that's impacting your community or another fellow dietitian, we really encourage you to share those stories because it helps us advocate together with a louder voice. And so with that, I know that there's been some questions in the chat and we've had some answers back and forth, but if there's any additional questions that someone would like to maybe unmute and share with the group, we have about 10 minutes left to maybe talk through that or have anybody share their experiences here and also give some moment to Kim as well if you'd like to share any additional context.
Hi, I'm Amy. I am a private practice dietitian here in Iowa too. I've been like 2 years now, I think. So very similar experience to Jen, just kind of fumbling through and figuring it out. So my biggest question about the Blue Cross, the Wellmark in general, is that fair? Right? Is that legal? Like, how is the answer of you're just not on the list? Okay.
Yeah, so well, you can start with Kim and then I think we'll have a follow-up with Domna as well.
Okay.
Yeah, are you specifically referring to the fact that they don't credential dietitians?
Yeah, they don't allow in Iowa for dietitians to be in-network providers.
So there's nothing that requires them to have to credential a certain provider type. There are many ways in which they can make benefits available to members, and sometimes that's incident too. While obviously we at the Academy believe that dietitians are the best provider of MNT, in terms of what payers have to, or in terms of what a payer, what provider types can provide what services, a payer type may choose to allow other different provider types to provide that service. So it's not illegal. It might be, it's not what one would prefer. It might be sleazy, but they don't necessarily have to credential a certain provider type. Now, with that being said, I'm working with both Iowa and South Dakota, to support them with some advocacy with regards to Wellmark and credentialing dietitians. And so we are going to hopefully be getting in contact with them and trying to have some conversations about, what that looks like and maybe what the barriers are, because at this point, from my understanding, those conversations have not been had with the payer. And so I have been a part of those conversations in other states. Sometimes, the reasons are, as Domna alluded to, you have these large payers, you would think that they would know what's going on in their system, but sometimes they simply just don't. And it takes getting to the right person to be like, hey, what's going on with this, and having that conversation. And so we're going to be trying to have some of those with Wellmark to see what the barrier is there. And so hopefully we can move forward with some advocacy work on that.
I think Kim makes a great point, and I think this is sort of where the eating disorder part is an interesting component because because of this mental health parity law, there are actually rules on what they do have to cover, and in regards to the providers who are who are being credentialed and what this process is based on. So one of the components is that if you're covering eating disorder treatment, you can't exclude a core component, which is medical nutrition therapy. And then you can't exclude the providers who mostly provide this treatment, which are generally registered dietitians. And if you were going to, it actually does need to be based on credible, reliable scientific evidence. And so this is sort of a way that RDs can actually push to have Wellmark and other providers cover and credential RDs because you don't have a separate eating disorder RD. So in order for them to comply with this rule for the behavioral health care code, it does need to be expanded to just RDs in general, because there is no There's not a specific, CPT code separate for eating disorder, MNT. There is not a specific licensing for registered dietitians that treat eating disorders. So, Kim is 100% right in that without specific rules and laws, they have a lot of flexibility. But this is kind of one of those areas where actually you don't have to be sure. Like you can bring this up to your local congressional person or a regulator, and you tell them exactly what you said. And oftentimes they will look into it and say, that does sound weird. And oftentimes with a lot of the big payers, they're companies, they don't want to look bad. And sometimes they kind of like to do oh my God, we're so sorry, it got lost. Our system was getting updated. And so there's ways to kind of convince these big payers through sort of like soft advocacy to do things because it's also in their best interest. And so I think, again, it's a lot of times you can't prove things or make things black and white. I mean, we like to think you can, but oftentimes it's just more of like, how can I play with this gray area? How can I be creative? How can I use sort of a mix of like common sense and also just like how people and systems work in reality?
So I think definitely answering Kara's the call to action at the end. That's part of where we are in our conversations with Kara, is sort of like gathering as much information as can be gathered to fully understand the situation, but also being able to take that to Wellmark or other entities to be able to have a conversation and sort of give the best sort of picture or presentation of the issue as possible.
Yeah, and so I can share a little bit about that too with you, Amy. So some of the soft advocacy would be kind of having a conversation around the fact that registered dietitians in Iowa are licensed, they are credentialed, they carry NPI numbers, and they do work with other large insurance providers as being an independent provider. So that would be some of the soft advocacy. But then in addition to that, being able to hear from our registered dietitians in the field of patients maybe who had Wellmark, who did not pursue care because they were too far away from an inpatient or in-network facility, and maybe they decided that patient pay wasn't a route for them. So hearing about people's stories, or maybe they are close to an area that has an in-network registered dietitian through the billing incident too, and there was a wait list, and they were having long wait times to be able to use their insurance benefit due to the issue of only a dietitian being billing incident to a provider. So hearing those stories and being able to kind of be able to create what the landscape currently looks like is going to help us in those conversations, because we want it to be a positive and working relationship with Wellmark. Because, in addition to that, it's really important that we have additional conversations with Wellmark about telehealth, because we know that registered dietitians and private practice, a lot of them are in telehealth. They're not necessarily in brick and mortar. So being able to have a really good open dialogue with Wellmark as we pursue this advocacy is really important to us. And so getting to hear from you guys about the challenges that you faced is really important to us to be able to paint that picture.
Yes, and I apologize if this was mentioned already, Kara. I had some family stuff that I was dealing with. But having these stories as well can help us to, be more informed when it comes to we have a lobbyist for the Iowa Academy, and while they're also focused on all these other issues that we're dealing with around licensure and the compact, to my understanding, our lobbyist also has a good relationship with Wellmark's lobbyist, and so they can also start that conversation, with the Wellmark lobbyist as well, and they have some experience with healthcare. So that's another way that we're using these stories to start that conversation and get input from our lobbyists on how they might be able to help us to start that conversation with Wellmark as well. Anything else you wanted to add to that? I don't know if I said that.
Yeah, no, that's great. Yeah, just all this. It's really been a joint effort with the National Academy and our public policy team and DomNut to really learn what are different ways to be strategic about partnering for advocacy, both for Wellmark and then potentially our next avenue would be with potentially with Medicaid. So being able to really learn the landscape and know what strategies and which levers to pull is really helpful. And I think working together is making us stronger. So, and that's another great thing from today is just being able to share with you guys that like we do know this is a concern of many dietitians in the state, and like we hear you and we want to make a change.
Yes, thank you. Well said. Well, with that, thank you all so much. You can email our public policy email if you have more questions or if you want to get involved. I have the Google form in the meeting chat for the testimonials if you'd like to share your stories.